Hi, everyone. My name is Yamara Edwards, and this is my case presentation. So let's get started. So very quickly, patient demographics. This is a 5-year-old Caucasian female. She lives with her parents and her sister. She attends school and after-school daycare. So patient comes in with her mom and her sister. The chief complaint per her mother was that my daughter has a rash. The onset was 4 days ago. One thing I do want you to know about this case presentation is that it's actually a combination of 3 office visits. So the first one occurred on day 2 of the rash onset. Second one was on day 4, and the last one was a week later. So by the second office visit, day 4, the rash has occurred continuously. There has been no improvement. It started off in her lower extremities, and then it has progressed to her entire body. It's red, it's inflamed, it's itchy, macular, and painful. Mom has given her some Tylenol to some relief. The biggest mysteries, though, is that mom could not identify where her daughter might have contracted this rash. So there's been no reports of rash at school or daycare. She denies that the daughter had been recently ill. No one in the household has been ill. Mom denies any new food exposure, any new environmental exposure. Daughter is up to date on our vaccinations because initially we thought, well, hey, maybe she might have chickenpox or measles or anything. And mom denies any recent travel. So going through the review of systems, she does have a little bit of a fever. She is slightly fatigued. And she just doesn't feel good. I mean, she's had this rash for 4 days now, has a little bit of a headache. It's painful, it's itchy. Tylenol is kind of providing relief. And so, yeah, she's not doing so hot in that department. One thing to note, she has no significant past medical history. This is a relatively healthy 5-year-old girl. No known allergies. So upon physical inspection, everything that I'm going to note, namely deals with the inspection of the skin. Everything else upon physical exam was within normal limits, but the rash is everywhere. I mean, it was even on the sides of her, it was even in her ear, it was in her scalp. This is kind of what it looks like. I don't have a picture of the patient. The only thing that I will note, which made the diagnosis a little trickier, was that the rashes actually appeared to be a deeper red. So it was more purpley than these. But same general appearance for the most part, just a little deeper red. Continuing on with the physical exam, again, just things that we noticed about the rash. It's confluent, it's erythematous and macular papular. It had some vesicles in some areas, but at the same time, it didn't present like chickenpox either. So we ordered some labs on that 3rd visit, just to, again, try to determine what was going on. For our differential diagnosis, the main one was hives. Another one was erythema multiforme. So that's something to think about as well, because it can present itself as hives, or rather the symptoms and its presentation look similar to hives. The last one is the Muckle-Wells syndrome. A little less likely. However, it can be characterized by episodic hives episodes. So getting a little bit into urticaria or hives, it's diffuse swelling that lasts less than 6 weeks. It's an IgE mechanism, or rather that's more commonly found in acute rather than chronic. Viral illnesses are typical for the majority of the acute hives. And other triggers may be infection, food, autoimmune diseases, that kind of thing. So the plan of care. So initially we had referred her to the children's ED because I think over those first two office visits, about 6 providers saw her. And because the rash wasn't presenting itself typically to anything that they can think of, they were just kind of at a loss as to what they thought it was. So the ED diagnosed her with just a bad case of really bad hives. So they prescribed her some Benadryl and some cetirizine and also some topical hydrocortisone. By the time she followed up 5 days later, the rash had been much improved. It was still persistent in some parts of her body, but at least it was better. One thing that was interesting, though, the mom was stating that if the patient was even an hour late in taking her medication, the rash would return. So again, a bit of a mystery. We referred her to allergy and to dermatology. We did those labs that I mentioned earlier, but those came back negative. So yeah, very interesting. The article that I had chosen sought to examine the effects of high-dose H1 antihistamine with urticaria. And what they found was that that high dose of those Benadryl type medications, they were effective with earlier age children, or they were effective with older children past the age of 10. And they prefer the high dose H1 antihistamines to any kind of corticosteroid in the outpatient setting. Level of evidence, I would rate it as a 6. This was a conclusion drawn from a single study composed of data files from a single hospital. But I will say that the generalizability, I'm not pronouncing that right, is pretty in line with the guidelines set for acute urticaria. What was also interesting was the study was mentioning about the use of corticosteroids, and that can't be fully endorsed because there isn't sufficient evidence to really support that type of treatment. One other thing that I wanted to mention is that these are photos of what I thought were similar to what the patient had presented, but they're two different things. So one of them was the erythema multiforme that I had mentioned earlier. And then of course, the one on the right is the urticaria. So it just goes to show you that different conditions can present themselves similarly. So you really have to be diligent in trying to figure out what the correct diagnosis would be. And it might take more than one office visit to figure that out. Some take-home lessons: even the most common of skin conditions can present themselves atypically. However, there are other skin conditions that can present themselves quite similarly. If the patient is in an acute episode of urticaria, consider that high-dose H1 antihistamine therapy for that initial phase. We don't know what the dosage was for our patient because she had returned from the ED and her mom didn't know the dosage. But something to keep in mind still. And also acute hives is more frequently observed in the ages of 3 to 8. And then the more chronic cases of hives are observed in older school-age children. And those might be more a result of autoimmune mechanisms. These are my references. And that is my case presentation. Thank you, everyone.